Hello, and welcome to this episode of In Discussion With from Medical Update Online. Today, I'm talking to Anthony Singh about pharmacist-led menopause clinics in the NHS, a service that featured as a trailblazer at the recent Royal Pharmaceutical Society Regional Conference in Birmingham. Please, could you start by introducing yourself?
My name is Anthony Singh. I am a lead pharmacist for North West Leicestershire GP Federation, and I'm also an accredited British Menopause Society specialist.
And can you give us a brief overview of your role, what your current job involves?
So my role is quite interesting. Lots of different facets to it, but I manage a team of about 30 pharmacists and some pharmacy technicians as well. I head up and manage all our projects, so our joint working collaboratives and our external projects that we have with third-party companies like University Hospital of Leicester, um, pharma companies, AstraZeneca, Pfizer, GSK, that type of thing. But in addition to that, I also lead our women's health hub across all 12 of our GP surgeries under the North West Leicestershire GP Federation banner, which includes 114,000 patients.
Interesting. You mentioned the Women's Health Hub. What is the Women's Health Hub and why did you decide to establish it?
So the Women's Health Hub was made about 3 years ago now, pre Conservative government's initiation of the Women's Health Strategy, which came out 2.5 years ago now, probably a little bit longer actually. And the Women's Health Hub was designed to give women easier access to women's health. So better smear management. So women that are unable to have a smear in a normal environment due to time constraints, or who who can get quite anxious, or is about tackling those patients who haven't had smears for a large amount of time and bringing them in. It was designed to reduce waiting times for long-acting contraceptions, so implants, coils. Often we find that some patients have to travel far distances or have to wait a large amount of weeks, which can increase abortion rates, and we wanted to try mitigate that as much as possible. But and finally, and very importantly to me, I wanted a women's health hub which focused on menopause care and reducing the barriers that were in place for women to access menopause care. Now, when I say menopause care, I don't mean just HRT. I want to look at the whole barrier that is everything under menopause, even if that's just knowledge, herbal treatments, as well as your everyday estrogen and progesterone. So yeah, they were the three main facets of our women's health hub. It has since developed, and we now do other pieces of work. So, for example, we work with the midwife service. We do physiotherapy for women for pelvic floor, that type of thing. But originally, it was just focused on those three things: contraception, smear, and menopause.
I'd like to focus on the menopause clinics. Can you say a bit more about how they work?
So with the menopause, there are always three KPIs. There's the same three KPIs for every project I do, to be fair. So key performance indicators, where I look at improving access to care for patients, therefore preventing that 8 o'clock rush that patients have to get an appointment. So I wanted to remove that barrier, hence why we do the appointment on an evening and on a Saturday, so they can still be seen by their normal clinician on a Monday to Friday, 9 to 5, but these are additional appointments. It's not about lifting and shifting. Another aspect of the menopause, and a reason why we do it, was to reduce secondary care referrals. So the amount of patients which GP surgeries move on to secondary care, causing that patient distress because they're waiting in our area 18, 19 weeks to get an appointment with a specialist. So I wanted to address that need. My vision there was to move the specialist closer to the patient rather than the patient having to move closer to the specialist, which is what traditionally happens with most secondary care referrals. Hence why our clinic is one of the very few where you get to see a menopause specialist in primary care rather than seeing someone in secondary care. And finally, but by no means least, probably most importantly, improving the knowledge base within primary care, thus achieving the first two KPIs, improving access and reducing secondary care referrals, because now more people across my 12 surgeries have a better baseline knowledge, a better floor of their menopause knowledge.
Very interesting. So, how does a patient access one of these clinics?
I hope easily. And when we look at feedback, we're always asking patients how easily they were able to get an appointment. So, quite simply, the patient would call their GP surgery as they would normally. The receptionists are all very well versed now. We've been doing this for a good few years, and they can book the patient into our central booking system using their current system that they already have in place. So, no new technology is needed, no new fancy process. It's just click at the top of their screen and it brings up all the appointments. They just right click and book the appointment of the patient an appointment. No additional form is needed, no additional process is needed. They just call the GP surgery as they would normally do so.
And does that avoid the 18 to 19-week wait?
Yeah. So the beauty of the service, now we've had it for a good few years, is we've been able to reduce secondary care referrals for patients at our surgery to the hospital by 24%, which is a huge drop, a lot more of a drop than I ever expected. And the reason why we were able to do that is because we were able to remove the inappropriate referrals, things that perhaps should be dealt with in primary care, but perhaps the individual didn't have the knowledge to at the time of that consultation for whatever reason. And we've also been able to deal with slightly more complicated patient scenarios, and then only the really complicated ones where perhaps it would need a physical examination or some sort of physical intervention, then they can be done within secondary care. I'll give you an example. A fibroid removal or polyp removal or an additional scan that we don't have the capabilities to do that within primary care.
Mm. Can you give us an example that illustrates the success of this service?
Quite a few. I think the common one, and one that I think will resonate with a lot of people, is the use of testosterone. Very popular, and can often be seen as quite a grey area, if you will. And traditionally, in line with guidance, testosterone can only be commenced by a menopause specialist. And most menopause specialists, by definition, work within specialist areas, i.e., secondary care or privately. Now, what we wanted to do was reduce that barrier to patients who would be eligible to go on testosterone. Now, that's not to say that we prescribe testosterone any more than those other areas. If anything, we prescribe it less. But we wanted to remove that barrier for patients. So if patients meet the criteria, then I or my team are able to commence them on testosterone with the correct monitoring to ensure it's done clinically safely, but in an appropriate time frame for the patient.
Hmm. The NICE guidance says that testosterone can only be given for reduced libido. Is that the way that you use it?
Yeah, NG23, which was the recent guideline written in October last year, um, stipulates it's very small, and I kind of wish it had more guidance there. And as a result, we take that, but we apply the BMS guidance, which is very similar to that of the NICE guidelines. But yes, the only reason that we can prescribe testosterone is for the diagnosis of HSDD, because we are working within hyposexuality dysfunction disorder. Uh, in English, low libido. Um, and that is the only reason that we within our team can prescribe it. Now, I absolutely appreciate that there may be benefits of cognitive function. There may be benefits to an increase in energy. There may be a better focus. However, the evidence supporting that is not large enough for that to be backed up within the guideline, hence why it's not in the guideline. But that's not to say it doesn't benefit patients in that way. And those patients that want to access testosterone for those treatments and not a low libido are effectively referred to secondary care for review. And the reason why we do that is because we, within our GP surgeries, have to work within clear markers, and any exploration outside of that leaves us open to critique. And from a governance point of view, we need to be making sure that we're adhering to guidelines.
I see. I understand that most testosterone products were designed for men and so contain quite large doses. So, which product do you use?
Traditionally, most menopause specialists or people that prescribe testosterone will often prescribe Testogel. Now, and the other option is obviously Tostrone in this country. Androfem has recently just been approved. The cream, which traditionally used in America, is prescribed by some private clinics within the country, has been approved by MHRA, but is not on the NICE guideline yet. That was only approved a couple of weeks ago. So to answer your question, I prescribe Tostrone, and the reason is from a clinical standpoint. I think it is unrealistic to expect a patient to eighth a sachet of a gel. I wouldn't expect anyone to do that in any other medication. You'd never say to someone, take a quarter of paracetamol or anything like that. So why would we expect a woman to use a controlled drug by definition and eighth the packet? So as a result, I prescribe Tostrone pump, which they would then use twice weekly, or we can increase that to 3 times weekly. But yeah, I pick Tostrone over Testogel, just from a common sense point of view, if I'm blatantly honest with you. We also will do a baseline free androgen index, total testosterone, SHBG, which is sex hormone binding globulin, and estradiol level. And then we'll do that at 3 months, 6 months, and then annually. We're incredibly diligent when it comes to blood tests, and we have a process that is adhered to. And then if the patient is deemed stable and is getting a good amount of efficacy from that medication, then I will then allow the GP surgery to continue that treatment going forward.
That's helpful. Now, moving on, how much has digital technology helped?
I think it's my USP personally. It is what sets me apart to every other menopause clinic in the country. I am younger and obviously a different gender to most menopause specialists, but it's my age and my ability to adapt to digital health that has allowed my clinic to be quite forward thinking. So for example, we use digital health throughout the whole process. So when a patient rings the surgery, we have the receptionist will book them an appointment electronically, and that's on a remote appointment. So I go in to do a physical appointment once a month, perhaps. And the reason why I like to do remote appointments, because you can do them quicker. I can see more patients that way. Consultations are about 20 minutes long. Pre-consultation, so once the appointment has been booked, the patient gets a reminder 2 weeks and then again 2 days before the consultation. And again, that's all digitally set up using a program called a QRX, which is a communication system that we have in general practice now, which allows us to communicate to the patient and the patient to communicate back to us. But I can set reminders within that to send correspondence to the patient to remind them they have an appointment. And it will also give me the ability to send them a link to rebook that appointment if necessary, to reduce the DNA rate, because I want as did not attend rate. I want as many, I want as least amount of DNA appointments as humanly possible. Now, otherwise, I would need a human to do that, and that's incredibly not cost effective. So we can do that within a QRX. In addition to that, in that text message, which is reminding the patient of the appointment, they also get a video. And that video, rather than a spiel of a text message, which we appreciate no one reads from their GP surgery, and we're all guilty of it, they click the video, takes them. I set it up using something called a Bitly. so it doesn't look like spam or something like someone's going to steal your bank details. It just looks like a professional link, and it'll say bit.ly Northwest Leicester Menopause Clinic. So the patient can identify that link and think, oh, I recognize that and I know what they click that link, it takes them to a video, and that video goes through risks, benefits, symptoms. It primes the patient to be ready for that appointment, so that their symptoms at the forefront of their mind. There's nothing worse than you turn up to a menopause appointment. It's already a difficult time in a woman's life, and they can't remember the symptoms because they've not thought about them in a couple of days. So they have that to prime them before the appointment, and also gives them the options. It is also a level of governance as well, if you will, because we've informed them already within that 4-minute, 11-second video about the risk of breast cancer, the risk of clots, etc. And then they have so the patient will then attend the appointment, usually by telephone or video link, and then once a month I will go in to a physical appointment because some people like that. Appointments are all done on a weekend and evening to allow for flexibility for patients. We're trying to reduce the amount of time women have off work, so it almost seems pointless to do a menopause clinic in a 9 to 5. We should be doing it outside because women work more than men in some cases. So hence why we do it in an evening and on a Saturday. Appointments are all done digitally using a system called Phone Bar, which again integrates into our GP record. So we don't have to dial anyone's number. So I'm not actually ringing some random person. The computer rings the patient. Therefore, the phone call is then recorded and can be listened back by my governance team should we need to. Again, another way that digital health helps us. There's a movie called Pursuit of Happiness where he dials numbers by hand and he identifies that cost him time. Therefore, by having Phone Bar, I reduce that time. Therefore, I can fit more patients, an extra patient I can fit in per day. So Phone Bar will call the patients. I know it's the 1%, but it's those 1% that add up. So the system calls the patients. We then use an AI system called Heidi AI. There are other ones available. A QRX has just come out with its version called a QRX Scribe. Upon getting permission from the patient, it then transcribes our appointment that both the patient and I contributed to in note form. And I can simply move that from the Scribe software into the patient's record. I then check that to make sure it is accurate, and then I can then save that to the patient's record. And then finally, or not just yet, but the next thing that we do is we send a video to the patient about how to use the medication that we've prescribed to them today. What we often found was when we looked at the reasons why patients were booking into appointments, one of the reasons was inappropriate bleeding or postmenopausal bleeding, as we originally presumed it to be. So irregular bleeding when we wouldn't expect it to be the case. And what we found was that patients weren't using the medication correctly. HRT can be complicated. When should you be using the estrogen? When should you be using the progesterone? By not using the progesterone, what will that cause to happen to a bleed, etc.? So we created AI generated videos which counsel the patient as well as the clinician already counseling the patient, but appreciating that the patient doesn't remember everything that happens in the consultation because there's going to be 300 other things that happen to them that day and they just want to get everything out in the consultation. So we now send a video to the patient telling them how to use the medication that we prescribed to them today, and then they're able to watch that millions of times afterwards should they wish to. Share it with their friends, I don't mind. All these videos are watermarked, if you will, at the beginning that say, thank you for attending Northwest Leicester Menopause Clinic, tell them how to use the medication. I can even make that AI their GP. So it looks like their GP. Therefore, it's almost a way of me creating personalized treatment plans. So patient then gets the video how to use medication correctly. We send the prescription electronically to their chemist of choice. They collect it, they commence the medication, and then finally, but by no means least, again, built into a QRX, no human involved here, the patient gets a feedback form, a simple Microsoft form, evaluating the service that they've received. And then that allows us to create the data and put ourselves forward for HSJ awards or primary care excellence awards. Ultimately, what we've tried to do is look at the full journey of the patient and where are the times where we can save time or money or an additional appointment, and we've addressed those needs.
This extensive use of digital technology is impressive. How helpful is patient feedback?
Often, as clinicians, we think we're making the best service or the best process because we know better. But what I found is we don't. My clinical director is a lovely man called Kirk Moore. He always taught me you don't know what you don't know. And I
Mm.
don't know menopause from a female's point of view. And that's the benefit of being a male who's done this. I've assumed nothing. And by assuming nothing and always not thinking you're wrong, but thinking there must be a better way of doing this, or how is this perceived from the female's point of view, or from the patient's perspective in this case, it's allowed me to make these improvements within our processes. Um, and as a result, I now stencil all of what we do into our other projects. So, for example, everything that I learn on the counseling videos for menopause, we also have a similar one for SGLT2s, for our SGLT2 project, which is a joint working collaborative with a pharma company, because we appreciate patients will get that medication from the chemist, and perhaps the chemist didn't tell them how to use that medication. Perhaps the chemist didn't tell them about water infections or washing their genitals correctly when they're on that SGLT2, and then they get a water infection. Whereas if they can just flip back to a video and think, oh, that's why that's occurred, this is what I need to do, surely that's a better way of going about it.
Hmm. And how has it worked out? What have you achieved?
Oh, look, more than I ever expected. So originally we just did 40 appointments. So way back before we got ICB funding from our local NHS, which came from the Women's Health Strategy a year and a half, 2 years ago now. Prior to that, we just did 40 appointments per week. Now we do 140 appointments per week. Like the service has expanded. It's gone from just to me and three other pharmacists. That's another problem that we identified, the cost of the service. If I was to have other clinicians who are perhaps more expensive, could we run an efficient service, or would it be more cost effective for me to put that training and money into more cost effective staff who would be able to provide a good level of care, but at the same time treat the patients to a good safe level? Then we looked at that avenue. So, and that's also helped me achieve that third KPI that I talked about previously, which is about that knowledge within the practices. So these people that now run the menopause clinic with me are all pharmacists that work at certain practices, but they also do my menopause clinic on a Saturday. So I've always tried to join things up. It's not just straight line. It's always trying to look at the bigger picture. So in terms of achievements, we were very grateful to receive the Clinical Pharmacy Congress Primary Care Excellence Award from David Webb. Well, that was the original one. And then a couple of weeks ago, we won the British Menopause Society Award on the evaluation of the project and how I will expand this moving forward. And finally, and no means least, the award I've wanted for a very long time. We're nominated for 2 HSJ awards, one primary care one and one innovation one. And those 3 have always been on my bucket list. I have 2 of them now, and this final one is there's a doubly a chance that I win one now, but obviously I'm up against some strong competition. But yeah, so it'd be nice to win the Primary Care Excellence Award. But I think the main achievement is the amount of patients we've seen, the amount of secondary care referrals we've dropped, so reducing secondary care referrals by 24%, increasing HRT prescribing compared to our neighbouring federations by 21%, pardon me, improving the number of staff that have completed accredited menopause courses with the British Menopause Society has 3x higher than it ever was. I think also the number of patients we've seen. So we've seen somewhere in the region of 1,800 patients now over the last 2 years. And please remember that's just on Saturdays and evenings. That's not included on what happens on a 9 to 5. One thing I always wanted to make sure that we're not lifting and shifting work. So GP surgeries are still open. It was not about moving those patients away from their normal GP appointment, moving them to a Saturday. It was about additional capacity. So we've always focused on that. So yeah, I think they've been the main achievements.
Very interesting. During your talk in Birmingham, you mentioned the impact on mental health prescribing. Can you say a little more about this?
So this was a nice outcome to look at. And it was based on a stereotype. I think a lot of patients commented on our feedback form to say it was nice to be heard, as I have often found I would normally be categorized as having a mental health condition rather than menopause, and as a result, prescribed antidepressants rather than HRT. Now, thankfully, the NICE guideline has changed and been updated and stipulates that first line treatment for menopause should be HRT. You'd think that would be obvious, but it's nice to have it written down. And what we wanted to show was that our menopause clinic was reducing the amount of antidepressants it was prescribing compared to our neighboring federations. That's not to cast shadow on our neighboring federations. What it was there to show was the benefit of having a dedicated menopause service would improve access to HRT. And hopefully inspire other people to create similar services to what we've created. So we wouldn't, not that I was expecting to, we weren't expecting, because obviously antidepressant prescribing is on the increase, and sadly we live in times where that is the case. The idea was not to create a negative, because that would have been really difficult, but was to level off that curve. And however, previously it was a 6% increase on antidepressant prescribing, we've now managed to flatline that. So no more patients are being prescribed antidepressants than would have done previously. And I hope that that means that more patients, as a result, are having easier access to HRT.
Now, your clinics operate through the NHS. It's not a private service. Was that the basic thinking here?
Yes, everything we do is done with the aspect that it will be free at the point of service. I went to university in Huddersfield. There was a statue of Harold Wilson outside the train station, and I believe everything that Harold Wilson stood for when the NHS was being created, effectively. The NHS should be free at the point of service. In addition to that, I am a northerner, and I appreciate I live in Leicester, but I grew up in Manchester, in quite a deprived area of Manchester. And I grew up not as fortunate as I am now, and my family could never afford specialized care. So my vision and my foundations have always been everything that we will provide will be free to the patient, because I believe that menopause is no one's fault. Not that it is anything bad anyway, but it's not something that women should have an additional tax on. The average cost for a private menopause appointment is £248. And I can't understand why a larger proportion of women pay that. I appreciate there is a need for private healthcare. Understand there are some patients that want a certain level of treatment that can't get that on an NHS. But I believe menopause to a basic level should be free and accessible on the NHS. One of the best things the Conservative government did previously, obviously, was create the prepayment certificate for HRT. It was a crime that women had to pay around £18 for estrogen and progesterone per month from their local chemist. Whereas now, or thankfully to the previous government, they created the prepayment certificate, so women pay 18, £19 a year. Now, to me, that made common sense, but why did it take us so long to get there? So my vision overall is to make menopause as easy to understand and treat within primary care as hypertension or diabetes or asthma. And then if you need to see a specialist, so be it. But the NHS should provide a basic level of service, as we do with all those other diagnoses.
In your talk, you mentioned community and patient engagement. Could you tell us more about this?
Absolutely. Menopause care isn't just about HRT. It's not just about the drug. Our duty as clinicians is not just to prescribe medication to patients. So when we created our Women's Health Hub, we looked at other aspects of menopause, community aspect. And when I looked at community, I wanted to engage our PPGs, our patient participation groups. I wanted to also increase uh, the amount of patients that were using the appointments, almost a form of marketing, if you will. So what we did is we communicated with our patient participation groups to organize group consultations. Now, we don't prescribe anything in these group consultations, but they are a platform physically, face to face, in a sports hall or a leisure hall somewhere. Again, all organized by the PPG. We get some digestive biscuits from the local co-op and some cups of teas. We invite patients in using a booking system. Again, they come in an evening after work and they've fed the kids, where one of me or my team will present to them on menopause, and we'll talk about risks, benefits, options available to them, but also how to access treatment. And obviously, we are providing that service free of charge from the federation, from the PCN, from the group of surgeries, reducing that barrier that patients can often say is that I can't get an appointment. Then we have a receptionist who sits at the door effectively, and then as patients leave, they're able to make an appointment should they wish to. We've also managed to improve that service a little bit better now. Any patients that attend, we obviously have their attendance details. We just send them an appointment via QRX. Should they wish to, they can just click the button and make an appointment at a time better suited for themselves. Within those group consultations, we don't talk about anything specific for an individual. We talk about menopause as a whole. We also engage with other aspects of the community. So, for example, we funded our local leisure centre, who have an umbrella called the Menopause Active Group. So they effectively enroll women and they take them to the local leisure centre, show them how to sign up to the gym. They bring in a nutritionist one week to talk about food and weight gain. They bring in a woman to talk about pelvic exercises. So we look at the whole aspect, incontinence, everything. And that's all organised by them, but we obviously fund it from our Women's Health Hub monies. We also get our social prescribers involved. Menopause can be a really lonely time. So our social prescribers can help organize these ongoing menopause cafes, if you will. If there are any women that are struggling with other aspects of their life, loneliness as an example, then the social prescribers can then join them up with other groups that are going on in the local area. Knit and Natter at the library at 11 o'clock being a perfect example. I've yet to attend. So yeah, we try to look at menopause as the whole big picture and not just the drug.
Mm-hmm. And what has the feedback from patients been?
The feedback from the patients is the best part, and to have 96% of patients to feel that they were satisfied with the treatment, 86% extremely satisfied, 10% satisfied is very nice to see. And whenever I have a bad day at the office, I will often have a look at those pie charts. And obviously, all that feedback is anonymous and voluntary. No one has to give feedback, and often in primary care, the only feedback we ever get is negative, because that's just the way that society is. So to get so much good feedback without pushing for it is incredibly rewarding, and it's that feedback which helps us expand the service, promote the service to other federations, and encourage other federations to create similar services. So yeah, feedback has been really good. From a clinician point of view, I'm always looking to look at everyone's feedback. So how can I make it more easier for my receptionist, for example? So as a result, we don't have waiting lists. So if a receptionist is unable to find an appointment, they will send that message to my admin team, and then they will book the appointment for them as soon as the appointment's go on. So we tried to look at everyone's feedback, not just the patient's feedback.
You mentioned the NHS Clinical Entrepreneur Programme. Can you tell us more about this?
The NHS Clinical Entrepreneur Programme is a programme set out by the NHS, done through a local university, where they encourage clinical entrepreneurs, people with ideas that work within the NHS, to develop those ideas in a safe space where you'll be supported. I've worked within cultures and environments previously where I had a lot of ideas, and sadly, those ideas weren't nurtured, and um, as a result, they just died a death. Whereas within my current environment, my federation are incredibly supportive of all my ideas, and they allowed me to enroll onto the NHS Clinical Entrepreneur Programme, where I attend certain pit stops around the country, and we learn how to turn my one hub into a national project. So that's what I'm currently working with a few different pharma companies. So I will quite simply set up many menopause clinics, as I've done across the whole of Northwest Leicestershire, around the country, with other willing federations and PCNs.
Mm, Clearly, there is a large unmet need. Does menopause care get sidelined?
Sadly, like a lot of aspects, menopause care can often be pushed to the side, and I, I found it my job over the last year and a half to really force it to the forefront, and it's been an amazing success. It has been good. There was a study done last year, 2024, called the Fawcett study, FAWCETT, and it is effectively a review of the women's health strategy. The figures it finds around women leaving their jobs or dropping down to part time are staggering. 14% of women change their hours to accommodate menopause. 10% of women left their jobs altogether because of menopausal symptoms. 53% of men didn't know that menopause was caused by a fluctuation on of hormones. There's such a big void and a gap that we need to fill.
Hmm, Interesting. So, what next? Where do you go from here?
Next steps. So first thing with the NHS Clinical Entrepreneur Programme is to set up similar projects around the country, and I'm going tomorrow where we will go and evaluate my service. I have a mentoring scheme with a pharmacist actually who works with NHS England that's helped me develop the service. And then we will quite simply roll the service out nationally. We've already been backed quite heavily by a few pharma companies who will take a standoff approach, but they're happily giving us the money to allow for me to set up these clinics around the country and train more pharmacists to become menopause specialists. In addition to that, to look at training. So one thing that I'm doing is looking at training hubs around the country and utilizing their access to pharmacists for me to provide training, free training to pharmacists on the basics of menopause. Even if that's just a simple review when you're doing your medication review. But my expectation is that all pharmacists will be able to review HRT and know exactly what they're looking at. Not be in the situation that I was 6, 7 years ago, where I was double guessing myself. I was having to, I'll call you back in a moment, Mrs. Smith. I just need to have a look at something. And that's not cost effective. And I appreciate it's strange being a 35-year-old male pharmacist that's doing this. And I've almost waited for someone else to do it for such a long period of time. And then it just kind of dawned on me, Anthony, if you don't do it, no one will. So yeah, that is the plan, quite simply. It's obviously very challenging with the changes that are going on within the NHS. There isn't always a women's transformation lead in place across certain ICBs. So I've created the British Menopause Pharmacy Society now, and it will be our remit to carry out education to bring pharmacists up to a basic level.
And finally, do you have a closing message for frontline healthcare staff?
In the famous words of Ted Lasso, I don't know if you've watched that, Christine. If you haven't, it is amazing. Be curious. I want clinicians to be curious about menopause, men just as much as females. I want us to look at basic resources around menopause. May that be the British Menopause Society website, may that be the NHS website on menopause, which has recently been refurbished and looks a little bit better, or the Women's Health Concern website, because menopause isn't complicated. If a 35-year-old Asian male pharmacist can learn it, anyone can learn it. And all the resources and all the information is all there readily available. Videos, documents, everything exists on the British Menopause Society website. So my advice and my plea to every clinician is access the free access and have a watch, have a read, because it'll help you treat your patients better. It'll help you have better clinics. It'll help you have better relationships with your staff and your family.
Anthony Singh, thank you very much for talking to us about this very important topic. We look forward to seeing how it develops. For more information about Anthony Singh's work and NHS menopause services, please visit the website using the links in the description, and be sure to subscribe for more news, videos, journals, and podcasts. For updates straight to your inbox, please follow the links below. And thanks for watching.